Okay, we're going to discuss diseases in mice now, and I want to take the same organizational tack that we did in rats, and that is we're going to discuss them by organ system and etiologies, and it will be in the same order. That is, the systems roughly are equal in importance in terms of disease expression, and this is really a repeat of what I had indicated in rats, so I won't go through all of it, but the same principles apply in terms of subclinical infections and host strain variabilities and expecting the unusual. I mean, all those things are similar in mice as they are in rats. So the first system I want to talk about is the respiratory system, because the respiratory system and the gastrointestinal system, certainly in mice, represent two systems in which there are common disease manifestations. And we're going to start with viral diseases, and certainly by far and away the most common and important viral disease in mice is Sendai virus. And this is a paramyxovirus that is quite common. It's highly infectious. It's difficult to control. And we had mentioned about it being a disease in rats to some extent, but clearly it is in mice in which it is the serious problem, by far primarily a problem in mice. Okay. We had, as I had mentioned earlier, there is great strain variability in susceptibility to the clinical disease. All right. I think many strains of mice are susceptible to infection, but depending upon what strain, you may see high mortality. For instance, the 129J mice, C3H BI mice, and the DBA2J mice have very high mortality to this, as opposed to C57 blacks and the NZB strains have relatively low mortality. So again, it's very important for you to determine what strain you're working with to get a feeling for what level of expression you're likely to see with this disease. Okay. Nude mice are susceptible to this. They develop a progressive emaciation that results in sporadic deaths. Okay. The epidemiology that we see, there are two patterns. The more common pattern is chronic subclinical enzootic infection, and then which is the one that you have to be concerned about most frequently, because that's the one that's hard for you to pick up. And then periodically these will bubble up into the acute epizootic pneumonias that are typical of the more severe expression or response to disease. Okay. Clinical signs involved with this, in very young animals, it may simply be neonatal mortality. And older animals, you may experience decreased weight gain or poor performance, and you may see dyspnea or hunched body posture. That may be a difficult thing to sometimes. How do you determine what a dyspneic mouse looks like? And actually, it requires that you get up close and personal with them to see that the animal is breathing in a difficult manner. Okay. Grossly, and again, the principles of trying to determine gross lesions in an organ that may be only a centimeter in length can be challenging sometimes, but typically you see the pattern of interstitial pneumonia, and that pattern is plum-colored foci in the hilus of the lung. Okay, hilar lesions to me say interstitial or vascular pathogeneses in the lung, as opposed to anterior ventral, which says bronchopneumonia. Okay, there may be secondary bronchopneumonia that occurs with this, of course. I mean, that's a common problem in viral pneumonias in many species, is that it's complicated by secondary bacterial infection because we've compromised the clearance mechanism in the lung. This is a gross photo of I know this is a Sendai pneumonia because it's experimental pneumonia. And here, all we see is that the lung looks congested. We can clearly see the pattern is beyond hilar to diffuse because the lung is quite red. Here, this little rim here at the edge is relatively normal light pink lung color. But the other thing is look how the lung is highlighted and glistens, and you can even see the water on the glass here. Okay, so the lungs are quite heavy and edematous as well, which goes along with acute interstitial pneumonia. Histologically, what we see is multifocal to diffuse interstitial pneumonia. And that may, quite early, there is necrosis of type 1 pneumocytes, necrosis of bronchiolar epithelium, and the response is neutrophils and alveolar macrophages. And early you may see some small perivascular cuffs, all right? With time and the resolutional phase of this, if the animals survive, there is type 2 hyperplasia and even squamous metaplasia in the alveoli. And the problem with this infection is that the regenerative areas, the regenerative foci, can be so intense that they look adenomatoid, so that you have these foci of adenomatoid proliferation in the lung, and that mimics lung tumor. And lung tumors are an important background pulmonary neoplasm in mice, and so it may be a problem in looking at that. Do I have early lung tumor, or do I have resolutional phase of Sendai viral pneumonia? And that sounds like a relatively moot or sophomoric point, but it's not, because if you have a wave of pneumonia that passes through your study, and at the time you're sacrificing the animals, you have this number of adenomatoid proliferations in the lung that you think are lung tumors. Suddenly your compound now looks like it causes lung cancer. Right? So here's another example about how intercurrent disease can create a political problem for you that may not necessarily be a biological problem, a significant biological problem for the animal. Here's a nice example of the way interstitial pneumonia looks like in the lung. It looks the same as interstitial pneumonia in many different species, and that is subgrossly you see that there's lots more parenchyma or cells than there should be airspace. And anytime I see that, I begin to be concerned about interstitial pneumonia. Here is a subgross of an entire lung from an animal that was involved in an inhalation study. There's an interesting story related with this, without compromising confidentialities. You can see that there is tremendous multifocal, widespread, but centered in the hilus, what on lower power resolves to inflammation in the lung. These animals were on an inhalation study, and part of the experimental design was to look at interferon levels in the bronchial lymph nodes of this animal. And in having some conversation with a study director during this, he was remarking to me how their interferon levels in the controls and in the different dosage groups were all over the place, and he couldn't figure out what the problem was. And one day, they had the immunology technician. I walked through the lab where they were doing sacrifices, and there were no pathologists involved in this study. And the immunology technician was just simply opening the animal's chest, clipping out the bronchial lymph nodes, and throwing the rest of the carcass away. And then they were doing their interferon determinations on lymphocytes isolated from the bronchial nodes. And I looked down into the chest of this animal, and I looked at this lung, and I said, you know, this animal's got pneumonia. Well, the immunology technician didn't recognize the gross signs of pneumonia, right? And so we started looking into this and realized that the animals had Sendai viral pneumonia, and it basically invalidated the study. And a nice example about how you ought to have pathologists involved in this at every phase that you can use a pathologist's input, because some experience would have told the people a long time ago, we've got an intercurrent viral disease here, we've got a problem here we need to pay attention to. I mean, this study cost millions of dollars, and basically they wound up with nothing. Okay, so early, again, there's nothing special about this. I mean, here we have some airways with acute epithelial necrosis, and we can see that there's inflammation out in the alveoli. Again, a little focus of acute neutrophilic inflammation following epithelial necrosis. Now, this is the subacute phase, or the more chronic phase of this, and I have had a couple of pathologists have looked at this slide and diagnosed a lung tumor. Right? So because the proliferation can be very basophilic and very adenomatous looking, it can be mistaken for a lung tumor. I mean, look at these cells here. Wouldn't you just be a little bit concerned about some of those cells? So real intense regeneration. And then here's a sort of here's a squamous metaplasia part. There's lots of inflammation in this one to maybe indicate to you that there's something more than just the proliferation, and maybe it's not just neoplastic. Okay. As in other paramyxoviral disease, okay, this is an immunosuppressive virus, and the model that we liken it to, of course, is canine distemper virus in our profession. So you need to remember that this is an immunosuppressive virus, and that the animals with sendiviral pneumonia may be susceptible to other infectious agents because of that. Okay, the second viral disease of the respiratory system that we need to be concerned with is so-called PVM, or pneumonia virus of mice. This is a strictly pneumotropic virus of low transmissibility, but it probably is more prevalent than we'd like to think. Okay, and again, I had briefly mentioned this with rats. Rats are susceptible, but it really is more of a problem in mice. Okay. We see, again, the epidemiology suggests low transmissibility. Probably enzootic infection is the rule, but you may get flare-ups. And certainly, I was privileged to do some experimental work with this a number of years ago, and we made lethal infections with this. I mean, you can give enough virus to animals to kill them, and we did so. Okay. Clinical signs in the natural disease, usually a subclinical, and I've got lots of experience of this as a natural disease, and can testify that subclinical infection is the rule. In the experimental disease that we created, we were able to create animals with that looked ill. Okay, so hunched body posture, looked like they were having difficulty breathing, all of those things, okay, that you would recognize as an ill mouse. Grossly, I think, indistinguishable from sendivirus. You see the pattern of interstitial pneumonia, or hilar plum-colored foci, and histologically, once again, acutely there is necrosis of bronchiolar and alveolar epithelium, which stimulates a neutrophilic response. There is vasculitis present with perivascular cuffs of lymphocytes, and it's these perivascular cuffs that persist for weeks after the interstitial pneumonia resolves that I think is the common expression of this that you'll see. And I'm going to show you some data in a minute to show you how we made some determinations about this disease going on in our facility. But quite commonly, as an incidental finding, you'll see these cuffs that last for weeks, depending upon when the infection occurred and when you sacrificed the mice. So here's our, again, this is kind of it's a small specimen, but here you can see this plum-colored depressed area in the hilus of the lung. I think all you could say was that, boy, it looks like I've got interstitial pneumonia here, and then I have to I need histopathology to sort out, what the nature of that is. And again, here's a nice illustration of how interstitial pneumonia is a hilar phenomenon. And here's the hilus of the lung, and you can see that that's where, at this stage, you can see that's where the infection or the inflammation is centered around, okay, as opposed to all being anterior and ventral, which is what you see with aerogenous insult to the lung. And here's very early, we see there are some sloughed epithelial cells, and there are neutrophils responding in the alveoli. Up close, a little closer, there's pycnotic debris, and there is some hemorrhage here. So again, sort of non-specific, but alveolitis nevertheless. Here are some early vascular changes. Okay, I mean, we can see it looks like there's some change within the wall, and then it looks like we have some cuffing beginning in the perivascular lymphatics here. All right, this would be very early. Here is early bronchiolar necrosis, epithelial necrosis, inflammation around the airways as well. No, unfortunately, no inclusions to nail it down. And then now, in the resolutional phase, you start to get some reepithelialization of the alveolar septi, and so these aren't really nice, tall, cuboidal epithelial cells, but this is recovery proliferation, okay? This is, I think, what persists for weeks, is often these sort of asymmetric accumulations of lymphocytes in perivascular lymphatics, all right? And I think that's kind of a hallmark of it. One of the institutions that I worked at, we were involved in some routine short-term studies, and again, when I went to this institution, I was sort of told that unfortunately we wouldn't see any spontaneous diseases of laboratory animals because the colony was very clean. All right. And in the 3 years that I spent in this institution, I think I saw every single spontaneous disease in rodents that is listed in the literature. And the difference is that I looked for them. All right? And I think, sure, if you don't look for the diseases, you're not going to find them, and it's easy to say we have a clean colony. But when you start looking for the disease, they're there. And this was one of the instances that started to force me to think, I bet there is disease here. It just needs to be uncovered. 2 different studies we looked at here, and I kind of looked at the PVM-associated lesions, and you can see here that in study 1, we had sacrifices at 4, 8, 28, and 33 days. In study 2, we had sacrifices 8 and 33 days, and these percentages represent the percent of the animals with PVM lesions in the lung. And you can see that with time, the longer the animals were on study, the greater the incidence of this disease was. And to me, this was evidence that we were propagating the disease in the colony. Okay. Okay. K virus. This is a very interesting papovavirus that occurs in mice. Mice of all ages are infected, but it really is a lethal disease in animals less than a week old. Okay, and I think that they develop, they acquire a resistance from this at about between 1 and 2 weeks, and then after that, it's a subclinical infection, and they become very resistant to it, and mortality is quite rare. And it's probably they receive this. It's passive immunity received from the dam. And again, enzootic infections are usually the rule. The disease or the infection is passed in secretions, so saliva, feces, urine. I mean, all of those things. It can be quite infectious. Okay. Most clinical disease is inapparent. And clinical disease is usually significant only when mouse tissues are being injected into neonates, all right? So, again, knowing your experimental manipulation helps you to rule in or rule out some diseases, okay? And so where are you likely to see this disease? You're likely to see this disease where suckling mice are being inoculated for some bioassay or something, okay? That's usually where you see it. Okay, the pathology. Gross appearance is that of interstitial pneumonia. Well, if you think diagnosing interstitial pneumonia in an adult mouse is a challenge, imagine diagnosing interstitial pneumonia in a suckling mouse. Okay, I mean, we're getting down to pretty small, right? And in fact, I'm not going to have any gross photos to show you. What I'm going to have is I'm going to have some whole body sections, and we're going to look at subgross, okay? But what you could reasonably expect to see are evidence of interstitial pneumonia, congestion, edema, in a hilar to diffuse pattern, petechia, atelectasis, plum-colored foci, and those things. Much more comfortable for us, of course, is the histopathology, in which we see the classic signs of interstitial pneumonia, and that is thickened alveolar septi. Okay, so clearly, when you look at the lung, there's going to be more parenchyma and cells than there should be. Mostly, it should be air. But here, we're fortunate in that there are some hallmarks of this disease, and that is markedly swollen endothelial cells, which have these prominent intranuclear inclusions. And so that, in a suckling mouse with the appropriate clinical history, should nail the diagnosis for you. And here is a whole body suckling mouse, and you can see here is the lung, and already hopefully you can appreciate there's far more cells in here than should be normal, and yet I don't see exudation out into the airways. Again, here is another more classical interstitial pneumonia, non-exudative. That is, I don't have lots of neutrophils and fibrin out in the airways, but I have a thickening of the alveolar septi, all right? And those thickened alveolar septi are because I have cellular infiltrate in these septi. I have blood and edema fluid, and then here are, if we look around, you can see that there are inclusion bodies. We'll get a little closer in the next one, in these swollen endothelial cells. Yeah, look at this. So nice inclusion bodies and marginated chromatin, so a very, very distinctive histologic feature, okay? Probably the lethal infection is probably related to the endothelial hypertrophy. And what does that endothelial hypertrophy do? It creates pulmonary hypertension. So extensive enough endothelial hypertrophy, I'm obstructing vascular movement through the lung. The heart objects to that rather vigorously. The heart has a limited range of objection before it goes on strike, and when the heart goes on strike, then obviously death is the result. Okay. Just to sort of put it in labor management terms. There are some other things, other viruses that cause interstitial pneumonia. One of them is adenovirus. This is, although there's nothing particularly characteristic about this, this is an adenoviral pneumonia. I think this is a rheoviral pneumonia, okay? Yeah, so I don't know that there are necessarily always inclusion bodies in the adenoviral pneumonia. Certainly I've seen adenoviral pneumonia in the lungs in which I've not seen inclusion bodies. Nevertheless, adenovirus and rheovirus would be two other viral agents that could cause interstitial pneumonia, and you have to take that into consideration when you diagnose interstitial pneumonia in mouse lungs. I'm not sure how common rheovirus is as a natural infection. All right, I get differing input. Nonetheless, I'd put it in my differential. Okay, bacterial diseases. And certainly, this may come as somewhat of a surprise because we have a tendency to think of chronic respiratory disease as being a disease of rats, but actually it is a disease that occurs in mice as well as in rats. And much of the pathology is the same. It causes a chronic mucopurulent bronchopneumonia with bronchiectasis. There are some differences, but in the main, many similarities. One of the similarities is this tremendous peribronchial or lymphoid hyperplasia, because mycoplasmal agents are nonspecific mitogens. And here is a nice subgross of, you can see that there is this mucopurulent inflammation in these big ectatic airways, okay? The histopathology may be somewhat valuable in that not so much the peribronchial or lymphoid aggregates, which are supportive of mycoplasma infection, but in mice, as opposed to rats, the infection tends to generate these syncytial giant cells and squamous metaplasia in the nasal cavity, which I'm not sure I see in the rat disease. So if you're looking at nasal cross-sections, I mean, that may be a way to help you nail that down. Obviously, there is submucosal glandular hyperplasia that occurs with some frequency in rodents, and of course, they also get this suppurative otitis media, just like the rats do. And here is a nice example of I had talked to you earlier when we dealt with this in rats about how the lymphoid proliferation can get so intense and so dense that I think that it may damage the resiliency, the compliance and resistance characteristics of the wall and permit ectasia or bronchiectasis. And here are these syncytial cells this is obviously a turbinate bone in a mouse, and here are these syncytial cells in the epithelium that have been described with this disease. I don't see that too often, but I'm not looking at this disease in mice too often, so. Okay, number 2 bacterial disease in the respiratory tract in mice would be Corynebacterium kucheri, or so-called pseudotuberculosis. And again, we went over this in some detail in rats. It does occur in both species with some frequency, with slightly different manifestations. I think the pathogenesis is quite similar in that latent infection is probably the rule. It's activated or reactivated by immunosuppression into active disease. And active disease is manifested by massive septicemia with emboli in many organs. To some extent, I think, at least in my experience, the common expression of this has been abscesses in the liver and the kidney, whereas my early experience with rats was the pneumonia, and now the last experience I had, we had metastatic abscesses in the kidney and the heart. So, you know, part of my view is biased by my own individual experience, and that may be a function of time. It may be a function of strain of the host. It may be a function of the strain of the pathogen. Okay. Nonetheless, you know, safe to assume that metastatic abscesses anywhere in a mouse, and you need to give this disease some consideration. Certainly here is, this is a mouse lung with multiple abscesses in it, for which we grew Corynebacterium kucheri from. Pasteurellosis. And the cause of this is Pasteurella pneumotropica. I think that this disease was once more common and a spontaneous disease than I think it is now. All right. Certainly, there aren't many examples of this in the recent literature. It does occur in both mice and rats, more characterized in mice than in rats. But its role as a primary disease agent is in question, and it may be an opportunist. It likely has a similar pathogenesis to pasteurellosis in cattle. Okay. What you see is multifocal suppurative bronchopneumonia, as you would expect pasteurellosis to look like in any species. And here is a nice example of, I mean, I could have taken this from a pig or a cow or a sheep and said, this is necrotizing bronchiolitis and bronchopneumonia, typical response to Pasteurella infection, and that certainly was what this is, okay? Again, you can see this is how it begins in the airway and spreads out into the adjacent pulmonary parenchyma as bronchopneumonia does. All right? So erogenous insult and pathogenesis. Okay, mycotic and parasitic diseases, certainly in that group we need to consider Pneumocystis carinii, but as we indicated, this is a generalized opportunistic infection in a lot of different species, probably most commonly seen in humans now in AIDS. but usually more thought of as a disease of rats than of mice, and it's probably because the rat was a model for it, the immunosuppressed rat was a model for it. Nonetheless, it does occur in mice, and I won't go into it in more detail than that because everything I said about the pathogenesis and the lesions is similar in mice as it is in rats. We get down to neoplasms in the respiratory system of mice, and primary epithelial tumors are frequent. They're very frequent in some strains of mice, like A strain mice, and you may see everything from bronchiolar carcinomas to bronchogenic carcinomas to metastatic carcinomas, and so there is the whole gamut of those, and you need to sort those out histologically, but certainly grossly they look all quite similar, and these white, well-circumscribed masses in the lung without a mass anyplace else to indicate that this is a metastatic tumor gives you a high degree of likelihood that that's what you're dealing with. And here is a primary lung tumor, pulmonary carcinoma in lung. So again, with some strains, it's quite common. Just up close and personal, looking at the epithelial proliferation in this particular tumor. Again, a different bronchiolar carcinoma here. This is arising from smaller airways. Grossly, I think they would look the same. Okay, let's go to the gastrointestinal tract. And beginning with viral diseases, there are some important viral diseases in the gastrointestinal tract of mice. One of them is epizootic diarrhea of infant mice, or so-called EDIM. And this is a rotavirus, exclusively of mice. All ages are susceptible, but clinical disease really occurs in mice that are less than 14 days of age. So once again, if you're buying your mice from someplace and you're getting them and they're all 6 weeks of age, you probably aren't going to see a lot of this disease as a clinical disease, okay? This is a highly infectious disease, as are, again, when you start getting into sort of the comparative pathology of these diseases, you see similar agents cause similar responses, have similar pathogeneses. I mean, rotaviruses are very, very infectious, and they're very infectious in rodents, they're very infectious in cattle, they're very infectious in human infants, okay? So they transmit very easily. The clinical signs, and one of the ways that we're going to use to differentiate between EDIM and LIVM, all right, which would be the next viral disease we're going to talk about, the coronavirus disease, is, and the way I remember it is EDIM live and LIVM die, all right? So there's low mortality in this disease. The animals do have diarrhea and evidence of fecal soiling around the anus. But the key thing is that they continue to nurse. So animals with the rotavirus continue to feed and continue to nurse. And that's probably responsible for the low mortality, right? They're losing fluids, they're losing electrolytes, but as long as they're replacing those and getting nutrition, they may pass through this phase and survive it. Because they continue to nurse, one of the characteristics of this disease at autopsy is the stomach is distended with milk. The colon and the cecum are distended with gas and have this soft mustard-colored, sort of a Plockman's mustard consistency stool, okay, very similar to the viral diarrheas or viral aniridities that we see in young pigs, okay. Some animals will develop an anal impaction. And here's a nice example of what these guys will look like. I mean, look at this. Look at these milk-distended stomachs, and then look at this. I mean, if this isn't Plockman's number 12, you know, I don't know what is. I mean, it's distended mustard-like stuff in the bowel, and it's glistening, and there's edema, and the histopathology of this is not remarkable. And again, those of you with experience in young pigs will recognize that rotaviral infection doesn't have much in the way of anatomic lesions. If you're lucky, and very early, you may see vacuolar change or hydropic degeneration in villus enterocytes, but not much inflammation. Cytoplasmic inclusions are reported to occur early on in the disease. I've never seen them. And here, this is about as good as it gets here. I mean, you look at these, there's some vacuolar degeneration in the villus enterocytes here, and this is acute edem, but that's about it. You know, we could argue that maybe there are a few more inflammatory cells than there should be, and maybe there's some edema there. That's certainly possible, but I can't substantiate that. The pathogenesis is probably similar to calf and human rotaviral enteritis, but that's not certain, okay? Certainly the differential diagnosis for enteritis in these animals will be libum, which we're going to talk about in a minute. Animals with reovirus 3 infection, and you'd have to give some concern or some consideration to salmonella and Tizer's disease as well. Okay, as opposed to the rotaviral disease, which may be relatively mild, lethal intestinal viral infection of infant mice, or so-called libum, which is caused by the enterotropic strain of mouse hepatitis virus, a coronavirus, is a serious high mortality disease. All right. These animals are in the 2 to 3 week range in age. So they're a little bit older than the cases of edem. And these animals too express clinical signs of diarrhea. But here the difference is that the animals develop inappetence. They go off feed, they lose weight, they dehydrate, and they die. Now I suppose if you took these animals and you put IV lines into them and you gave them supportive therapy and did all of that you'd probably be able to get them through this, but you have to ask yourself the obvious questions, right? So what you see at postmortem is fundamentally different. And that is the animals have an empty stomach. They have a thin-walled, gas-distended intestine that isn't very full, right? And the bowel does have a sort of a fluid content to it. And again, you know, think of this as mouse TGE. Okay, this is transmissible gastroenteritis of pigs in the mouse. It's a coronavirus. Nice example, contrast. Here's a relatively normal animal as opposed to this one. And look, this is this milk-distended stomach. There is no milk-distended stomach here. And this animal, if you look a little bit, this animal just looks dehydrated. I mean, he's shriveled up, he's drier, he's not quite as filled out as this animal. And this animal has libum. The histopathology, there is villus atrophy and blunting with necrosis, ulceration, vacuolar degeneration, and more inflammation than we see in edem. And again, if you review your findings about TGE in pigs, you'll recognize that the villus atrophy and villus blunting is a hallmark lesion for coronaviral infection in neonatal pigs. Same in mice. Okay. A distinctive feature in this disease, not seen very frequently in pigs, is the presence of multinucleated syncytial giant cells. And I have seen this in older animals, in different strains of mice, in older animals as a subclinical infection. But just as surely, I believe that those animals probably have subclinical and enterotropic strain of MHV infection that's subclinical, right? Here's a nice example of early lesion here, and again there is vacuolar change here, and this is an early lesion, again as a non-specific response to this, but again sort of up close and personal, again a little bit more serious than in the rotaviral infection. And look at this. I mean, here we're starting to lose epithelial cells. We've got some crypt dilatation and little crypt abscesses here, more inflammatory cells. And then look at this. Boom. I mean, the villus enterocytes are just sloughed off and gone. And eventually this will collapse. This will collapse and form that sort of blunted villus. Okay. This is, I think, a manifestation of this disease. This is in an adult mouse with no clinical signs, but these are the kind of syncytial epithelial cells that I think represent the presence of mouse hepatitis virus infection. Okay, bacterial diseases. And the hallmark of bacterial enteritis, or bacterial disease in the gastrointestinal system in mice, is enterocolitis. Certainly first on the list is Salmonella enteritidis and Salmonella typhimurium. These are important, serious diseases in mice, and serious for a number of reasons. Partially what we had discussed earlier. Clearly in this disease, subclinical infection is far more important than clinical disease, but once again, subclinical infection can create a nidus for enzootic infection. In my experience, I've been fortunate to have some experience with this disease, and we had just that. We began to have sporadic death loss in animals that had some of the lesions of which I'm going to show you. And then pretty soon we started seeing animals that were clinically not, near-do-wellers, not doing well. And again, we isolated Salmonella from a number of these animals, and pretty soon, over a period of weeks, we realized that we had enzootic salmonellosis that had become epizootic salmonellosis and created problems for us in interpreting a study and how to deal with a study. And if this happens 12 or 14 or 15 months into a study when you've got hundreds and hundreds of thousands of dollars tied up already, what do? It's difficult to make the decision to slaughter all those guys. By the same token, you carry a study on now, and it is flawed by the presence of an infectious disease that may inhibit interpretation of the study. So the best of all possible worlds is to have a good colony in which you don't have this disease in the first place. Okay. Anyway, what you see is just exactly what we saw, and that is sporadic enterocolitis that becomes acute septicemia. Grossly, you may see everything from no gross lesions to some visceral hyperemia. To me, the common things we saw were multifocal white dots in the liver. Sometimes the liver was pale, but characteristically you'd see multiple foci of acute coagulation necrosis in the liver and sometimes in the spleen as well. Now, when we get to the liver, I'll review there are a lot of things that cause multifocal white dots in the mouse liver. Histologically, what we see is enterocolitis with ulceration and necrosis, neutrophilic inflammatory response, hemorrhage, all of the things that characterize bacterial enterocolitis, okay, as opposed to viral enterocolitis. Often there is ulceration and necrosis and neutrophilic inflammation. Splenic and hepatic necrosis goes along with this, although we're focused right now on the GI tract. And with time, that may progress to granulomatous inflammation or so-called reticuloendothelial hyperplasia in those organs in which there is a significant complement of reticuloendothelial tissue or fixed macrophages. And again, we'll review that a little bit when we get into the liver and the spleen. Here is an example of intestinal tract in which there is, you can see this is relatively normal when we get around here, and here's an area of ulceration and secondary suppurative inflammation forming a pseudomembrane or diphtheritic inflammatory response. Very typical of bacterial infection in the intestinal tract. Another area in which there is epithelial necrosis and loss and neutrophilic inflammation following underneath that when we breach that mucosal barrier and expose the body to what's in the intestinal tract, intestinal lumen. Another case, a little bit more chronic, we can see that there is more of a granulomatous inflammatory response here with scattered neutrophils. Again, cultured salmonella from all of those. Okay. The pathogenesis of this disease depends upon the ability to penetrate the GI mucosa, replicate in Peyer's patches and lymphatics, and spread to the lymph nodes. And you get secondary replication in those sites, and then bacteremia, now beyond the enterohepatic circulation. And that's when you get septic embolization to liver, spleen, and other distant sites. So it very much depends upon the invasiveness and the invasive virulence properties of the bacterial agent. You know, unfortunately, although the immune system can hold this in check, there is a tendency for salmonella to persist in lymphoid tissues, and the gallbladder is a nidus for this, so that there are carrier animals. And just as there are typhoid Marys, are carriers in humans, there are carriers in rodents, and they may be difficult to detect, and that's how you create this low-level subclinical infection often, and you probably buy it. You know? Okay, Tizer's disease. Tizer's disease is caused by Bacillus piliformis. Although we're dealing with it here as a disease in mice, you recognize that Tizer's does not have a narrow range of host specificity, but in fact, we briefly mentioned it in rats. It occurs in other rodents. As you know, it occurs in foals. And so I think it has a wider host spectrum than just rodents, although the pathology is quite similar wherever you see it. Again, subclinical disease is far more important than clinical disease. But although the signs of illness are nonspecific, this can be a very toxic agent, as many bacilli or bacilluses are, and so sudden death may be the only thing you see. Grossly, what we see at autopsy are signs of enterocolitis, and now again, just focusing on the gastrointestinal lesions. The enterocolitis may be expressed as anything as a normal to slightly thickened intestinal tract to one that is hyperemic and dilated. Histologically, there's epithelial necrosis and hemorrhage, ulceration, neutrophils. We may see increased numbers of lymphocytes and plasma cells in the lamina propria. And of course, this is an intracellular bacterial agent. So characteristically, you would expect to see intracellular filamentous rods. We're used to looking at this disease in livers much more frequently than we are in the intestinal tract. I don't know that I'm going to be able to show you any intestinal lesions microscopically, but here's an animal that does have both. It has hepatitis and enteritis as well, and enterocolitis. And here is this red and thickened bowel. I don't, this is a case of Tizer's, but I'm not sure that I have any organisms to show you in this field. Again, there is nonspecific ulceration and necrosis and inflammation. Again, a differential diagnosis is going to be salmonellosis, okay? So you need to get down and look for those little haystacks in epithelial cells. Here is a little crypt abscess. A nice firm evidence that you've got inflammation in the bowel. It's often difficult to appreciate that you have enterocolitis if all you have is just an increased amount of lymphocytic, plasmacytic inflammation in the lamina propria. And the question always becomes, how do you diagnose lymphoplasmacytic inflammation in a tissue that ordinarily has a complement of lymphocytes and plasma cells? Because then it becomes a judgment call, right? Well, I think this bowel has more lymphocytes and plasma cells than it should. That's pretty subjective. By the time you get to crypt abscesses, that's objective. By the time you start putting more granulocytes, neutrophils, eosinophils, that's a little bit more objective. And those are correlative signs that I really, in fact, do have inflammation in the bowel. Otherwise, we're sort of caught with, and this would be true in all species, we're caught with trying to diagnose lymphoplasmacytic inflammation, which I think is way, way overdiagnosed in small animal practice. You know, we fall into this inflammatory bowel disease thing that we lay on every endoscopic biopsy of an animal that has vomiting and diarrhea, right? So, well, excuse my sermon there. So. Oh, I think we're at the end of that carousel. Can we break? Yes. Okay. Why don't we break? Bacterial disease of the gastrointestinal tract that we should consider is Citrobacter freundii infection, which causes the disease transmissible murine colonic hyperplasia. This is a disease of variable morbidity and mortality. Once again, as is a consistent theme, depends a little bit on the strain of mouse that we're looking at. The disease does not occur in rats. It is confined to mice. And characteristically, the clinical signs associated with this are soft feces and a rectal prolapse. And that is the classic sign. I will tell you that I lived through an epizootic of this at one institution I worked at, in which we have the lesions. I'm going to show you the lesions from that outbreak, and never saw a single rectal prolapse. So once again, I don't know whether they were A-strain mice that we were dealing with. Maybe A-strain mice don't prolapse their rectums when they get Citrobacter freundii infection. But here is an example of what rectal prolapse does look like. It's just a puckered out anus, but that is the typical the disease associated with that. I don't know what the pathogenesis of it is, although it may likely relate to straining, as many lower bowel diarrheas cause straining, and it may be the prolapse is secondary to that straining. Okay, but the lesions at autopsy that are characterized are quite characteristic, and that is a thickened, opaque, contracted distal colon. And histologically, the lesions are also quite remarkable in that there tends to be diffuse, marked colonic epithelial hyperplasia, hence the name of the disease, transmissible murine colonic hyperplasia. However, as is a common theme in recognizing anatomic changes or anatomic lesions, that is often the severest lesion. The diffuse lesion is often the one that's most difficult to recognize because there's no normal to contrast with it. And so we may overlook diffuse hyperplasia because we don't have normal hyperplasia to alert us that a portion of this is abnormal. It's a conundrum, I think, in pathology that often the severest lesions are the ones that are more difficult to pick up unless you have enough experience and perspective to recognize clearly this is tremendously altered or markedly altered, and then that's how you make that change. Okay. There is variable inflammation associated with this. Peritonitis has reported this, and I'll show you those lesions Anyway, here's an example of normal and this thickened distal colon. You can see it's quite easy to pick up grossly. It was so in our experience. And here is the so-called jelly roll approach to looking at intestinal lesions in mice, which you take the intestine and you wind it around a pencil and then fix it, and then you cut that. It looks like the cross-section of an onion, but it allows you to look at large segments of the intestinal tract that might be otherwise difficult to look at. But here is tremendous epithelial hyperplasia and inflammation that may be difficult for us to appreciate until you compare it with normal. And I've placed in here for you normal and Citrobacter infected colon so that you can appreciate the size of the change. I mean, this is relative. This is the size of normal colon, and again, taken at the same magnification. Look how much thicker it is. It may be 2 to 3 times mucosal height, and the cells tend to be very basophilic and very proliferative, and hopefully with some experience you would recognize that there is tremendous hyperplasia occurring in the colonic epithelium. There may not be a lot of necrosis. There may not be a lot of inflammation. So you have to have that in mind when you're looking at it. Look at this again. Look how tremendously elevated. This is probably about 3 times the depth of that normal I show you. And of course there is inflammation down in here to alert that for you. And again, the animals are reported sometimes to have peritonitis, and this particular animal does. We're looking at the backside, so this is all serosal inflammation. Here's the mucosa, and the animal does have suppurative inflammation that is spilled out through the serosa, so this animal did have peritonitis with it. Okay, let's move on to bacterial and mycotic, mycotic and parasitic infections, and there are several that we need to consider. The first is Spironucleus Murus, or the old name for this was Hexamida murus. This is a pear-shaped flagellated protozoal agent that causes clinical disease in young mice who are stressed. All right. In the florid clinical manifestation of this, the animals will have diarrhea and may suffer high mortality in young mice. And again, I don't know that that's anything significant about the virulence of the agent so much as it is, as our experience in human medicine, florid diarrhea in infants who have a difficult time regulating their fluid and electrolyte levels can be a fatal experience. And so the same would be true in these diarrheas, in florid, profuse diarrheas in young rodents in which their fluid and electrolyte levels aren't being met. And we saw that in some of the viral diseases. It can be so in bacterial disease. And now here is a parasitic disease that may result in high mortality. And it's probably related to fluid and electrolyte loads in efficiency in maintaining those. I don't have a lot of experience seeing the gross on these. A reddish-brown distended GI tract, which is fluid and gas-filled, is reported. Sometimes, if you're lucky, you can see the protozoal agents in the intestinal tract, and here certainly is an example. Your eye has to be cocked for these to recognize what these look like, because as is true of many flagellates, they're not invasive. All right, so they're not invading into the tissue and therefore causing an inflammatory response. That they're producing diarrhea by biochemical means. And so there's not going to be a lot of anatomic change because there's not a lot of invasion and therefore inflammation, necrosis, or whatever. All right. Probably best diagnosed by perhaps fecal smear. You have to be lucky to see them in section, although they have been, in a way it's like E. coli infection, that these things are associated. They probably need to adhere to villocenocytes to create that biochemical lesion. Okay. A second parasitic disease of some importance is the flagellated protozoan Giardia murus. Some of you are familiar with this as a cause of diarrhea in dogs. And often, again, this parasite is as many of the flagellates appear, as a pear-shaped organism. this is a relatively low pathogenicity, and again, diarrhea is rare, and so the association between severity of diarrhea and apparent response to infection sort of goes hand in hand, okay? You may see these adhering to villus enterocytes in the small intestine as well, and there may be some yellowish-white sort of non-specific fluid bowel syndrome, okay? And I don't think I have any of these to show you. This is, although this can be looked for by fecal floats or in fecal smears, our colleagues in small animal medicine frequently diagnose this by response to treatment. We, of course, shouldn't be diagnosing things by response to treatment in rodent medicine, because if we're down to where we're treating rodents for diseases, we're already in trouble, right? A third and somewhat sporadic, but when it occurs, can be a real problem, as it was in this case, is coccidiosis. There are a variety of coccidial agents in mice, some of them of low virulence, some of them of high virulence. I was fortunate in my career to be at the right place at the right time, where we experienced an outbreak of Eimeria falciformis in mice. Eimeria falciformis is one of the high virulent or more pathogenic species of coccidia in mice, and so we had much clinical disease, and we had animals dying from this, okay? Like coccidia, the disease is very much like coccidia in ruminants, or at least in bovines, and there is infection of the colonic epithelium. We had the whole gamut from subclinical infection to lethal infection, and histologically what I'm going to show you is epithelial necrosis and hemorrhage and lots of gametocytes and sporozoites. Again, this can be readily diagnosed by fecal float. The problem is that a certain amount of coccidia may be there normally. That's a low virulence or low pathogenic strain, and so I'm not sure in what the finding of those means. It means you may potentially have a problem. It means you might not. Just some. You can see some sporozoites again, and this is just book photos of some of the stages. And this is what they look like in histologic section. Again, there were abundant parasites present in our disease outbreak, and I think these are from fatal infection. And you can see here, again, you can see here all the Eimeria here, and then there is tremendous epithelial necrosis and secondary inflammation and ulceration, and probably these animals are susceptible to secondary bacterial infection. Certainly, you'd have to be concerned about endotoxic shock if you create this kind of necrotizing or colitis. Okay. It caused quite a stir. This outbreak caused quite a stir amongst the laboratories on the bioassay because it had popped up sporadically in some other laboratories besides ours, and I don't think there had been reported outbreaks in the United States for some years, and so there was concern about what's happened, by the animal suppliers, and I don't know what finally resolved from this. There were papers written and conferences held and telephones rang, and I think that's all settled down now. So certainly mice, this is Hymenopus nana, which is a tapeworm that occurs sporadically in mice. The key here is that there is both a direct and indirect life cycle on this parasite, and that it is zoonotic. That is, this is transmittable to humans. As in most adult tapeworm infections in most animals, it's relatively subclinical and without pathologic significance unless the loads get really, really heavy. Nonetheless, you may see this from time to time as an incidental finding in laboratory mice. And again, this is it's pretty easy to tell this is a tapeworm. You can here in this case you can see some segmentation here, but remember that tapeworms do not belong to that class of animals that have no body cavity, which would be tapeworms and trematodes, but the animals don't have a digestive tract either, and so getting down to the diagnosis of tapeworm should be pretty straightforward. Also, mice commonly have pinworms, and the common pinworm in mice is Xiphacia obvalata. And again, there is no significance to their being there, but you probably need to record it as an observation, and you'll see them and you'll need to deal with them. And they differ a little bit from tapeworms in that they do have a body cavity and an intestinal tract, so it's pretty sophomoric to be able to differentiate nematodes from tapeworms. Neoplasms in the intestinal tract of mice are relatively rare, with the exception that when we get down to the hemic-lymphatic system, we'll see that mice have a significant and relatively high incidence, strain-dependent again, of leukemias and lymphomas. And one of the manifestations of leukemia and lymphoma in mice is that there is an intestinal lymphoma that occurs just like it does in dogs and cats. And this is such. You can see that there is diffuse, involving about 270 degrees of the circumference here, thickened infiltration of the bowel wall with immature lymphoreticular population. And again, I'm not going to go into the classification of these. It's changing, and in fact, I'm with a group of people that are trying to standardize the nomenclature for these around the world. 2 years ago, we took steps to do that in rats, and now I think that we're taking steps to standardize this nomenclature in mice as well. It's a little bit more complicated in mice than it is in rats. Hepatobiliary system. And I'd like to start with viral diseases of the hepatobiliary system, and any consideration of that would have to deal with mouse hepatitis virus right up at the top of the list. Mouse hepatitis is caused by the hepatotropic strains of mouse coronavirus, or mouse hepatitis virus. Okay, so mouse hepatitis virus comes in enterotropic strains, hepatic-tropic strains, and we'll see when we get to the nervous system, it comes in strains that are specific for the central nervous system as well, so neurotropic strains as well. This is a disease that is confined to mice for the most part. The clinical disease varies tremendously, once again, with host strain, viral strain, age, and other enhancing and inhibiting factors, which could be stress and those things, okay? It is, unfortunately, it is a highly, highly infectious, common, and serious disease. It's a devastating disease of nude mice, just a devastating disease, and I've been involved, directly involved in 2 outbreaks and indirectly involved in a 3rd outbreak, all of which resulted in having to depopulate the colony. And the two outbreaks that I was involved in at one institution I worked at, each time we depopulated the colony, it cost $40,000. So not an incidental problem, okay? Not an incidental problem. The way to deal with mouse hepatitis virus is to not have to deal with mouse hepatitis virus. Right? The clinical signs are both acute and chronic, depending upon, again, all the factors that we talked about. Certainly in acute disease, there may be the signs of nonspecific depression and tremors and huddling. You may see dark urine, and that may relate to hepatitis and bilirubinuria. More commonly, you may see in the chronic expression of this is wasting and ascites. This is a serious disease in animals. I mean, many animals may die or have to be sacrificed. And again, the mortality is quite variable depending upon strains, but may run right up to 100%. What you see at postmortem is what you're going to see in many of these diseases that express themselves in the liver, and that's multifocal hepatic necrosis. And so grossly, it may be very difficult to sort out the different causes of hepatitis in mice. But they are varied, and the list keeps getting longer and longer, all right? And to some extent, obviously, those that may have inclusions in them or there are agents that you can see, those tend to be more specific. But quite often what you're going to hear me say is that the histopathology is coagulation necrosis with neutrophils and some complement of inflammatory cells, and sometimes it's granulomatous. But in this case, the disease tends to be somewhat acute, and the animals die in the acute stages. So what you see is coagulation necrosis and the early response of neutrophilic inflammation. With hepatitis virus, you may get lucky and see karyomegaly and syncytial cells and basophilic inclusions. Certainly would be the most common cause of this triad of changes histologically. And here, this is an example of multifocal white dots in the liver caused by a mouse hepatitis virus. But I mean, you know, this could be salmonella, it could be Tizer's disease, it could be pseudotuberculosis. I mean, at this level, it could be a lot of different things causing acute necrosis in the liver. This was a nude mouse. So this was from the outbreak that I was indirectly involved in when Tom Rosel, who was a colleague of mine, was doing his work on transplanting anal sac carcinomas in dogs and growing them in nude mice. He suffered this epidemic of mouse hepatitis virus in his colony, had to destroy his whole colony. So here again we see roughly multifocal coalescing white dots in the mouse liver, and this one caused by hepatitis virus. Here is acute coagulation necrosis. Again, we're looking at an example of hepatitis, but it could be a lot of different. Diseases. Again, here is acute necrosis with some evidence of hepatitis from an outbreak of hepatitis. Same thing. Okay, a little different manifestation, a little different expression. Again, same thing, a little different manifestation of the disease. And here is an example of one of the syncytial cells. Remember, we saw syncytial cell formation in the enterotropic strain of mouse hepatitis virus as well. So here it is in the liver. And here's a nice internuclear inclusion body. Here's another one. Right, to sort of help you lean towards this being coronaviral hepatitis. Okay, certainly another viral disease of tremendous importance to us is ectromelia or mouse pox. And actually, it's a pox virus that's a highly contagious, devastating disease, okay, that occurs in multiple different forms. And actually, we're going to cover different forms of this in some different systems. And right now, I'd like to just deal with the hepatic manifestation of this, okay? It's not a particularly common disease. There was an outbreak about 15 or 20 years ago in North America, but it's not very common. But when it happens, it can happen with just dramatically rapid, fatal results, okay? Often, again, susceptibility is strain variable probably on both sides of the equation, both host and virus side. But if the animals survive the initial septicemic phase, you may see chronic skin diseases that we'll talk about when we get down to the skin, okay? And there are obviously subclinical infections as well, so. The pathology requires consideration that this is a systemic disease, even though you may see liver involvement or you may see more commonly skin involvement. It is a systemic disease. There is widespread severe lymphoid necrosis in lymph nodes, and especially in the spleen, okay? Conversely, multifocal hepatic necrosis occurs in only about 15% of the cases. So while multifocal hepatic necrosis needs to include ectromelia or mousepox infection in it, It's not one of the more common manifestations of the disease. And when we get into the spleen and lymphoid tissues, that's where we'll see some things that should lead us to believe that that's more of a problem for us. Okay. GI hemorrhage occurs in this disease. There are cytoplasmic inclusions in the liver, GI, pancreas, urinary tract, skin. It's a systemic pox infection, okay, and it behaves like systemic pox infections in other animals. All right. You know, our experience, for the most part, as mainline veterinary pathologists, when you say pox, I think of swine pox and I think of fowl pox, which tend to be sort of localized infections, okay, and often cutaneous infections. When you get out of those models and you get into sheep pox or you get some of the other species, there are systemic diseases that are devastating, and ectromelia is one example of those. This is, again, there's nothing special, I don't think, about this. This is acute hepatic necrosis due to mouse pox infection. Again, another one here. Again, this is from, I don't know that there's anything distinctive about this, but I can tell you that the slide is from a case of ectromelia. So I don't like to show you slides of things that are from something else and say, well, it could be this. I just don't like to do that. It may be that at some point in time we'll discover some subtle things in there that will help us determine that, and I'd like to be able to come back to that material and say, here's the lesion. Here is an inclusion body. Here's a cytoplasmic inclusion body that occurs in pox. All right, so if you see those, that certainly may be helpful to make that diagnosis. Okay, and we will revisit mouse pox when we talk about cutaneous disease. All right, another viral disease that expresses itself in the liver is reovirus. All right. Again, there is a wide host range. Probably the norm is subclinical infection. I don't know as a cause of spontaneous disease in adult animals whether this is very common or not, but certainly spontaneous disease has been described or reported in neonates. Clinical signs, these animals may have stunted growth. Interestingly, they may have an oily hair coat, which is related to steatorrhea. And the animals have steatorrhea and diarrhea partially because they have decreased lipase and amylase. And that's related to the fact that there is acinar degeneration and necrosis in the pancreas. So in this case, oily hair coat that goes along with the diarrhea and the icterus because there's hepatitis present. And they have CNS signs because when we get to the nervous system, reovirus has a central nervous system manifestation as well. So what do we see at autopsy? Well, again, multifocal hepatic necrosis or multifocal white dots. We may see Councilman-like bodies, which would be cytoplasmic inclusions. I've never seen those, but they're reported. There is cytomegaly and neutrophilic inflammation and lymphoplasmacytic inflammation, signs of chronic active hepatitis with bile duct proliferation. Again, all somewhat non-specific manifestations of hepatitis, but lesions that you might recognize or diagnose as hepatitis. In addition, there are myocardial lesions, there are pancreatic lesions, there may be salivary necrosis, and encephalomyelitis and neuronal necrosis, and which we'll revisit when we get back into the nervous system. Okay. It is the acinar degeneration and necrosis in the pancreas that may lead to obstructive pancreatitis, and it is the pancreatic involvement, of course, that results in their inability to digest lipid, and so they have steatorrhea. This is not a very common disease in my experience. I have limited experience with it. Okay. Here is a case of hepatitis caused by reovirus, but There's nothing here that I think specifically points to this as being reovirus hepatitis. This is reoviral pancreatitis. Okay, so you do see inflammation in the pancreas. Not many things cause pancreatitis in mice. Another viral disease with expression in the liver is lymphocytic choriomeningitis, and this always gets our attention because LCM is an arenavirus that is zoonotic, obviously, with ramifications for humans. In mice, this occurs as a latent infection. Cutaneous disease is rare, but congenital infections can occur. And it is the visceral form of this that we're most concerned with right now. In the visceral form of LCM, there may be lobular hepatitis with necrosis and nonspecific signs of inflammatory disease, okay? Clearly, there's an immune-mediated pathogenesis to this, but I don't think you're going to see this very commonly, all right? I don't think this is very common. The pathogenesis is well worked out, but I don't know that in terms of spontaneous disease that it's that well known. We will revisit that again when we look at encephalitides, okay? Okay, bacterial diseases manifested in the hepatobiliary system or the liver, and certainly the one right up on top of the list is salmonellosis, right? So we talked about salmonella early as manifestation of enterocolitis, and now it's a function of multifocal white dots or multifocal hepatic necrosis. That may be anything from early, it's coagulation necrosis, to late little granulomatous nodules, and these are typhoid nodules, or the so-called typhoid nodules from human pathology that we've known about for years. All right. And again, here is I've been involved. I was again fortunate to have been involved in an epizootic of this. Unfortunately, I didn't have any good or gross photography available to me at the time. So I've sort of relied upon a picture of white dots in the liver here. Notice this animal has some splenomegaly as well, which should go along with salmonellosis. But lots of microscopic manifestations of this. And here is, you can well imagine how you can see this area of coagulation necrosis and early inflammation that's bulging up the capsule here a little bit. You could well appreciate how this would be visible as a white dot at autopsy in the liver. Okay, and this right here up on the surface. Again, from a different part of the liver, but again, you can see there is acute coagulation necrosis of hepatocytes with some attendant inflammation that's inciting attendant inflammation peripherally. And then this is up close and personal with a so-called typhoid nodule. So we've gone past that acute stage to where we've got probably phagocytosis and ingestion of the salmonella that persist intracellularly in macrophages or Kupffer cells, and forming these little nodules. And again, if these got large enough, you could appreciate these grossly in the liver as miliary white foci, all right? But once again, the manifestation at gross would be multifocal white dots. Okay, certainly second to salmonellosis amongst bacterial hepatidities would be Tisser's disease. And I mentioned this briefly with rats and indicated that this is not a species-specific organism. In fact, people who are involved in equine autopsies are well aware that this is well characterized in neonatal foals as well. Nevertheless, multifocal yellow-white foci is what you'll appreciate grossly. And microscopically, these look quite different than the foci of salmonella or even the foci of pseudotuberculosis, in that they tend to be discrete foci of intense necrosis and with suppuration. That is, there are many degenerate neutrophils present in these foci, and then around the rim of these foci, within hepatocytes, are these little haystacks filamentous rods. Okay. One of the things to help you sort out the white dot problem, all right, is that there are no lesions of Tisser's disease in the spleen. So that may be one of the ways to differentiate mousepox, because mousepox, when we get down to hematolymphatic system, mousepox impacts predominantly the spleen. Most of the time there is tremendous lymphoid necrosis in the spleen. So you've got white dots in the liver but no splenic involvement, you're likely to be able to rule out or rule in Tisser's disease, okay, and rule out mousepox. Here is a case of multifocal white dots, and these white dots were foci of acute necrosis. Again, here's another multifocal, not quite as well, but again, another case of Tisser's disease. A nice example of florid multifocal coalescing white dots of Tisser's disease. And this is very typical of what you see in Tisser's, in my experience, in all species. And that is a discrete, multifocal, discrete foci of acute coagulation necrosis and pus, degenerate neutrophils, as well as degenerate hepatocytes. And then around the rim, and that's where you look for the agents, is right around this interface, the rim there are intracellular rods. And I don't know how well you can see those here, but you should be able to, because the lights I can't see them, but hopefully you can see amply illustrated here intracellular bacteria. Okay. These stain with, I believe they stain with Gram stain and a number of other special stains very well, but in my experience, if your eye is prepared for these and you know where to look, you can make that diagnosis without the special stain. Okay, Corynebacterium cucuri infection, or pseudotuberculosis, certainly, and again, is an important and relatively common cause of multifocal familiary white nodules or white foci in the mouse liver. Okay, and again, we've talked about this in a number of contexts. Certainly, everything from acute disease with high mortality to chronic infection is what you see, depending upon all of the variables that we've gone over before. The pathology, again, is as this disease manifests everywhere. That would be raised grayish-white caseous nodules. They may be confined to the lung if you have them, or they may be confined to the liver if you have them in multiple other organs as well. That's going to help you lean towards Corynebacterial disease as opposed to one of the other diseases, perhaps. And then microscopically, when you look at those, they are suppurative to granulomatous, and there are gram-positive small rod-shaped bacteria that help to establish that diagnosis. And here is a liver of an animal that has small Corynebacterial abscesses in it. Just as a parenthetical note, let me indicate also that there are other bacteria that may cause hepatic abscesses. So not all abscesses are going to be caused by Corynebacterium. Certainly that's a common cause, but we've seen disseminated abscesses in animals due to Pseudomonas and Klebsiella as well. So you can't, it's not a given that you're dealing with Corynebacterium. Okay. All right, mycotic and parasitic diseases expressed in the liver in mice, none are particularly frequent. And if we get down to neoplasms, and then we do have to deal with some common ones, and the common ones would be lymphoma. And this is an example of diffuse lymphoma, up close and personal with lymphoma in the liver. And then we also have to deal very commonly with hepatocellular carcinomas. And these occur with very high frequency in some strains of animals. For instance, in aged C3H mice, 80 to 90% of the animals by 24 months may have hepatocellular carcinomas. So again, one of the reasons I think you as a pathologist need to be consult at study design. And one of those things might be strain selection. If the people you're working with need to have really clean livers without neoplasms in them, you might want to pick another strain besides C3H mice. And those are the kinds of inputs that I think you have as a pathologist, and your knowledge as a pathologist can help in study design and help before people spend a lot of money and put a lot of time into study and find out that we have a poor design, and the power of our experiment isn't very strong because of that. Okay. These usually appear as solitary nodules in the liver, but depending upon when you see them, they can go from very small to quite substantial in size. Histologically, I don't think it's very challenging to diagnose those. And we looked at those in rats a little bit. They tend to be well-differentiated plates of hepatocytes. Some people have tried to subcategorize those, and that's fine if you want to. It's certainly not my interest or view here to subclassify neoplasms for us, okay? In the area of miscellaneous diseases, certainly biliary cysts or bile duct cysts are not uncommon. These are relatively easily recognized as smooth, round, cystic masses filled with translucent, pale tan serous fluid. I don't think there's any clinical significance to them. And other incidental lesions in the hepatobiliary tract, I like this one, is pancreatic atrophy. And again, this can be quite striking when you're not prepared to see this. But basically, the atrophy is acinar atrophy only. This animal has functional islet tissue. Okay, so there's not diabetic. But I mean, you know, where are the acini? All right. The relationship between this and pancreatic insufficiency is very questionable. All right. I don't know that that's a common phenomenon in rats that you would think. I mean, you know, where's the pancreatic function? I mean, certainly if this were a dog, right, there'd be lots of pancreatic insufficiency. I don't know that that's very well characterized in mice at all. Okay. Nervous system, all right, and certainly as equally as bewildering as hepatitis is in mice, certainly encephalitis, there is a list of viral agents that cause encephalitis, most of which is non-specific, non-suppurative encephalitis with neuronal necrosis. But nonetheless, I think we'll review the agents that cause those, okay? Number one on my list is Tyler's disease, or mouse polio, and this is an enterovirus, just like poliovirus is in pigs and in humans. And this is caused by the TO strain of, or Tyler's origin strain of enterovirus. Also, you'll see this referred to as GD7, which stands for George's disease. It's interesting how these things get labeled, right? That was named after George Martin. You'll also see this called mouse encephalomyelitis, or MEV. And it's, again, quite similar to the experience of polio in primates and in pigs. Usually it's a subclinical infection, but a small percentage of the animals develop disease. And the classic clinical signs associated with this is flaccid paralysis. Okay. While that's the classical clinical sign, all right, it's been reported to occur in 1 out of 10,000 animals, so it's not very common. And again, it's an example of how, boy, here's a striking clinical sign, and so we start associating striking clinical signs with the disease, and pretty soon, you know, we get to the point where we think, well, you know, this happens in a high percentage of the disease. Not so. Striking, but not very frequent. Okay. The pathology of this can be biphasic, all right, In the early stages of this, there is acute non-suppurative encephalomyelitis with necrosis in the brain and the ventral horn of the spinal cord. And then the second phase of this is a delayed demyelinization. And that's probably related to autosensitization from myelin, all right? And so in some respects, it's similar to experimental acute encephalomyelitis, or so-called EAE. And this may be controlled by iatrogenic immunosuppression. So those are the reasons why this is believed to be autosensitization of myelin. A differential diagnosis for flaccid paralysis in mice is cage trauma, and probably a more frequent cause of flaccid paralysis in mice is cage trauma. And again, at some institutions that I've worked with, when we have those cages, we have individual wire cages that house small numbers of animals. When the animal is handled and he's put back in the cage and the cage is closed, and sometimes if you smash that cage down on his back, you create fracture or disease in the spinal column, and he gets flaccid paralysis, because basically you've damaged the spinal cord. But then now your concern is, well, maybe I've got enterovirus infection. And here is an example of, again, we're going to look at a lot of these histologically, in which there is non-suppurative encephalomyelitis and neuronal necrosis, but I don't think any of these are going to be sufficiently distinctive to help you separate out, the different viruses. Other than the fact that here's an example of gliosis and encephalitis here that is caused by the polio agent. Again, here is acute sort of laminar chordal neuronal necrosis. Okay, a second disease of the central nervous system causing non-suppurative encephalomyelitis is so-called demyelinating encephalomyelitis caused by the neurotropic strain or the JHM strain of mouse hepatitis virus. So hepatitis has impacted the gastrointestinal tract, the hepatobiliary system, and now the central nervous system. Mice of all ages may be affected. The clinical signs are flaccid paralysis again in the hind limbs, depression, and perhaps CNS signs. There are no gross lesions. Microscopically, though, there is, again, acute neuronal necrosis that seems to be concentrated in the hippocampus, and demyelination in the brainstem and meningitis. And this is a little bit different from the enteroviral disease, the pathogenesis, in that there is now evidence that there is direct viral infection of the oligodendroglial cells. So the demyelinization, rather than being autoimmune, is due to cytolytic infection of the myelin support cells, or the oligodendroglial cells. And again, this is non-specific encephalitis here. There is glial cell proliferation. Looks like there's some spongy change, maybe some neuronal necrosis, but nothing that's going to tell you that this is mouse hepatitis virus. You're going to need serology or culture to confirm that. Again, nice. I've taken an interface picture here. This is in the hippocampus. These are normal hippocampal neurons, and then boom, abruptly there is all of this necrosis and spongy change. And here is some demyelination in the spinal cord, again, secondary to oligodendroglial infection by neurotropic mouse hepatitis virus. I have to briefly mention reovirus infection. Once again, this is usually a subclinical infection in mice. I don't know how commonly this occurs as clinical disease in adult mice. Certainly their spontaneous disease has been reported in neonates. Again, this is a rehash a little bit of when we talked about the disease in the liver, but the animals do have stunted growth and an oily hair coat and diarrhea related to the steatorrhea, all right? To reiterate, the multifocal white dots in the liver, but there are extrahepatic manifestations of this disease, one of which is encephalomyelitis and neuronal necrosis, all right? And, oops. Here is an example of again, this is non-suppurative encephalomyelitis and neuronal necrosis, and again we can see glial cell activation in reovirus 3 infection. Again, same thing here, although I don't believe there's anything here to distinguish this from the other causes of encephalitis. Again, similar disease. Okay, a brief word. There is a cerebral form of lymphocytic choriomeningitis that is only related to intracranial inoculation. All right. So again, the subclinical form of this disease may manifest itself as hepatitis. You won't see non-suppurative meningitis in this disease unless there is intracranial inoculation, and then these animals will have convulsive seizures and often have clinical signs. And the disease is very much related to the immune status of these animals. Animals that have a normally intact immune system, the disease is fatal, and the animals in which there is suppressed immunity, there is persistent infection and no disease. So to some extent, this is an immune-mediated disease in which you have to have a normally functioning immune system to respond to this. Otherwise, there's no clinical disease. Okay? And there's nothing special about the pathology of this except mild non-suppurative meningitis is the manifestation. This is an example of, just very briefly, of the non-suppurative meningitis that occurs in lymphocytic choriomeningitis, and so named because it's lymphocytic and involves the meninges. Okay, so you see it's not very florid. This is from a case of LCM in a mouse. Okay, we'll move on to encephalomyocarditis virus, and this is caused by a picornavirus, and it should be in your differential, but remember, this is a spontaneous disease in swine, primates, and elephants only, and not mice. It's an experimental disease in mice. So once again, if you look at your experimental protocol and can rule that out, you could rule out EMCV infection as the cause of the encephalitis that you're looking at, okay? It does tend to be a disease of neonates. Again, neonates are often the age class in which we're injecting something into, okay? The clinical signs, again, are flaccid paralysis. There's a common theme here, right, in terms of viral infection in the central nervous system. But flaccid paralysis, lethargy, and death associated with injection of neonates. And when you look at the pathology of this, Non-suppurative encephalitis is a general response. There is necrosis in the brain. There may be lesions in the heart as well, hence the encephalomyocarditis. And there may be liver, kidney, and pancreatic manifestations as well. And this is an example of experimental encephalomyocarditis virus infection. And here is the encephalitis, and you can see there's neuronal necrosis here, but there's nothing here that is distinctive of the picornaviral disease. Again, here's another example of necrosis, and you can see there's lots of glial cell or rod cell activation here in this focus, but nothing especially indicating this viral agent. A brief word about rolling disease. Now we're looking at bacterial diseases in the central nervous system, and of course we need to consider our old friend Corynebacterium, obviously, and other septic abscesses that would be caused by other agents, Klebsiella perhaps, Pseudomonas perhaps. All right, and then third on our list is Mycoplasma neurolyticum, right? And this is a common latent infection, but disease is only related to experimental inoculations. Most mouse strains are susceptible. And there's a pretty, the clinical signs are pretty classical, and that is CNS signs within an hour after IV inoculation, okay? So if you're inoculating something and you see CNS signs pretty rapidly, you've probably inadvertently instilled this agent or created this disease, okay? There are no lesions if death occurs in less than 8 hours, and then if it goes beyond that, you may see some astrocytic degeneration in greater than 8 hours, okay? It's important because it's a common latent infection with disease potential, and that's the only reason why I mention it. It is an exotoxin. It is the exotoxin that causes the symptoms. So rolling disease. You probably never hear about it again in your life. Okay, we're down to mycotic and parasitic diseases, and I had mentioned earlier Encephalotozoan caniculi, which is a microsporin agent that occurs in many species, and certainly mice are one of those. We looked at I showed you a granuloma, a typical granuloma from a rat. The pathology is quite similar in mice as it is in rats, and it's quite similar to what you would see in rabbits, okay? Multifocal granulomatous encephalitis with lymphocytic perivascular cuffs, and you may see some interstitial nephritis. Interstitial nephritis is considerably less frequent in mice than it is in rabbits, for whatever that's worth. And here is a very nice example of one of these cerebral granulomas. You can see that there are epithelioid macrophages surrounded by lymphocytes, and I have seen organisms outside adjacent to these lesions, but not very commonly. Okay. Okay, neoplasms. We're down to neoplasms. Primary tumors, primary central nervous system tumors are pretty rare in mice. We get down to miscellaneous lesions, and this is one of these miscellaneous lesions that probably is strain dependent, but it's multifocal cerebral mineralization. It occurs primarily in the thalamus, bilaterally in the thalamus, in vessel walls, and it increases with age, and beyond that, the pathogenesis is undetermined, and I don't believe there's any clinical significance associated with it. Nonetheless, you'll see it in the brains of aged mice, and you'll have to deal with it. Cardiovascular system. Okay, viral diseases that impact in the cardiovascular system, and the response usually is myocarditis with necrosis. And one of the diseases that causes this is adenovirus, right? And there are some strain variabilities in this. The FL strain is lethal in suckling mice. The K87 strain is subclinical infection. Again, you know, those are sort of minute details that I don't really want to wallow in. Adenoviral infections may persist for quite a while in mice. All right. But what we tend to see is multifocal to extensive myocardial necrosis and inflammation, and if we're lucky, there are internuclear inclusions in the myocytes and vascular smooth muscle cells. We already covered the expression of adenoviral disease as an interstitial pneumonia in lungs, so that I don't want to go back over that, all right? You may see inclusions in GI epithelium with no disease. Okay, I've never seen that, but it's reported. And here's an example of adenoviral myocarditis. Obviously pretty severe inflammation and myocardial degeneration and necrosis. And again, this is up close and personal, and I believe that there are some viral inclusions here. And again, this is a manifestation of this disease in the lung. And I think that I should be able to show you, I guess not. I guess I'm not going to see inclusions in this. Oh yeah, here it is, right there. So here's an inclusion. Nonetheless, myocarditis in a mouse, and you should consider adenovirus as a potential cause, okay? Also, you might want to consider Rio3 virus infection. This would be a second cause of myocarditis and necrosis. There are no inclusions. And remember that these animals will have, and this is such a focus of reoviral myocarditis. Remember that there are secondary clinical signs associated with reovirus infection, icterus, oily hair coat, diarrhea, and those things. Again, up close and personal with myocarditis and in reovirus infection. Myocarditis. Oh, I'm sorry. Actually, that's the third cause of viral myocarditis that we're looking at. That is encephalomyocarditis virus. Okay. But remember, that's not a spontaneous disease in mice. So it's a disease of experimental manipulation and inoculation only. So I would put it in my differential diagnosis as what's possible, and then eliminate it based upon history if you can. But this is a case of the picornaviral disease. Bacterial diseases, and that's not what this is, but the bacterial diseases that we need to consider in mice is Tisser's disease. And again, I showed you an example of what myocardial necrosis with intracellular bacteria in the heart looks like when we looked at rats. And so it's probably not important to show you the same lesion in mice. And ditto would for the Pseudotuberculosis or Corynebacterium cuceri abscesses. We looked at those abscesses in the rat case that may also occur in mice. And then as a sort of a generalized septic bacterial diseases, again, the Klebsiella, the Pseudomonas, the spurious bacterial agents may settle in the heart and cause myocardial abscesses. So you need to consider those. There are no mycotic or parasitic diseases expressed of any importance expressed in the heart. The same for neoplasms. There are no primary neoplasms in the heart. But there, in the area of miscellaneous diseases, this is certainly a very common strain-dependent disease, and this is epicardial mineralization. And again, this it's quite strain dependent. This is another example. I remember the first time I saw this as a young pathology resident. It looked, first of all, it looked for all the world like fibrinous pericarditis, and then I thought maybe it's uremic frost or gout or something like that. But and then you start looking and you think, well, maybe it's massive myocardial necrosis because I'm looking at this sort of white dense stuff on the heart. But histologically, it all resolves to this massive amount of mineralization in the epicardium. The incidence varies quite a bit. It was initially reported in a narrow range of strains, and now it's recognized in a wider range of strains. Okay. And you may see this as early as animals in 90-day studies. So this is animals that have been on study for 3 months. And usually those animals are bought at 6 to 8 weeks of age and spend a couple of weeks in solitary confinement of quarantine. So we're talking about animals that are as young as maybe 5 months of age will begin to have this disease. So you need to be aware of it, and because it's an obvious gross lesion, and you have to deal with it if it pops up in your columns of your studies. And another miscellaneous disease is atrial thrombosis. We briefly talked about this with endocardial disease and with myocardial degeneration in rats. It's more frequent in aged mice. There probably is some relationship between this and eventual congestive heart failure, as you would guess. Just having that mass in the atrium, the cause of it is uncertain and unknown. It'll be at best a sporadic finding. The urinary system, okay. Viral diseases of the urinary system, not very common. You may see adenoviral inclusions in the endothelium in the glomerular vasculature. Mouse pox may impact as foci of hemorrhage in the kidney and in the bladder. In late onset disease of lymphocytic choriomeningitis, there may be chronic immune complex glomerulonephritis. All right? And all of the ramifications of what that looks like, but again, not very common. Bacterial diseases, and certainly bacterial diseases are manifested by purulent or suppurative inflammation. And again, I'm not going to show you a slide of this because we looked at it in the rat, but surely Corynebacterium abscesses would be first and high on the list. Okay, so hematogenous spread to the kidneys is very frequent in mice with this infection, probably stress-related or iatrogenic steroid-related. And I mean, where that comes in for us is that if you're administering a compound or the animals are on test and that compound has immunosuppressive properties, boom, you're setting yourself up for the opportunity to experience immunosuppressive diseases, one common manifestation of which would be Corynebacterium septicemia and abscesses. Okay. Also, bacterial cystitis would be a leading to urinary obstruction, would also be a secondary manifestation of bacterial disease, although we'll see in a minute that there is another probably more common cause of urinary obstruction besides bacterial diseases. When we get down to mycotic and parasitic diseases, there aren't many, but renal coccidiosis is recognized in mice caused by Pseudotuberculosis Murus. It may be very common but incidental in some strains of rats or mice, depending, okay? And I think this is, this is a little bit more up close and personal than what we looked at, but this is coccidial agents in the proximal tubules. I don't know that there is any significant clinical significance to the disease, okay? Neoplasms, primary neoplasms of the urinary tract are generally rare with the exception of lymphoma. All right, so the principal manifestation of lymphoma sometimes may be renal lymphosarcoma, either unilateral or bilateral, so you need to keep that in mind when you're looking at masses of white or enlarged white kidneys. Amongst the degenerative diseases, the principal one would be glomerulonephritis. Again, this is highly strain variable. Was certainly with NZB mice because of their ability, their propensity to develop early immune complex disease. They are predisposed to immune complex glomerulonephritis. This is the other disease that would be strain dependent and common, which would be amyloidosis. And this is an example of amyloidosis, I believe. No, I'm sorry. This is glomerulonephritis, and this is amyloidosis. Okay, so a fine line of difference, perhaps sometimes. Amyloidosis is a high incidence in some strains. It may begin as early as 6 months, and in some, by a year, 100% of the animals will have typical glomerular lesions. Okay, so again, strain is very important in sorting those out. Some incidental diseases or miscellaneous diseases that you should be aware of, and certainly one classically described one is chloroform nephrosis. In some strains of rats are extremely sensitive to chloroform, and results in acute tubular necrosis or an acute nephrosis and high mortality. And there certainly must be an established relationship with testosterone, because the disease, only males are susceptible in some strains. These animals may be so exquisitely sensitive to it that simply keeping a chloroform container in the same room with the animals, and if you take the top off to pour that chloroform out, is enough chloroform to cause nephrosis and mortality in every single male mouse in that room. So the answer is be careful where you keep the chloroform jar, okay? And it probably has to do with renal excretion of chloroform metabolites in the presence, mediated by testosterone, so in the presence of testosterone. So an interesting, and here's an example of such a lesion, okay, and there's nothing particular about it, acute nephrosis. Polycystic kidneys certainly occur as a sporadic, mice are very urinary organisms, right? Have a lot of urinary diseases. This is a nice classic example of mouse urologic syndrome or obstructive uropathy in male mice. Notice the seminal vesicles here, and probably secondary to a seminal plug. So the animal develops a plug of inspissated semen in the urethra, and that causes outflow obstruction just like a blocked cat. And these animals obviously can get pretty big bladders. Hydronephrosis is, again, just as in rats, hydronephrosis is a sometimes sporadic finding in mice. Okay, hemic-lymphatic system. Amongst the viral diseases, certainly the viral disease of most significance is mouse hepatitis. Is mouse pox. And the hallmark lesion of mouse pox is widespread, extensive lymphoid necrosis, especially in the spleen, okay? And characteristically, the spleen is involved in 95 to 100% of cases. So it's very characteristic. And the message here is don't diagnose ectromelia unless you've got splenic lesions, all right? Now, early and in the acute stage, that the lesion is lymphoid necrosis. If animals survive that, and many do, you'll get resolution by fibrosis or granulation tissue. And so in the chronic spleens, you'll see splenic fibrosis. Nonetheless, evidence that the animal did have and recovered from pox viral infection, okay? We're looking at this in the integumentary system, but that's forgivable here, I hope, okay? This is an example of massive lymphoid necrosis in the spleen due to mouse pox. There isn't anything else I can think of in mice that causes this extensive splenic lymphoid necrosis. Again, lymphoid necrosis secondary to mouse pox infection. Okay. It's been said, or the old saw is that splenic necrosis in a high percentage of mice with an epizootic disease is strong presumptive evidence to diagnose ectromelia. briefly looking at viral diseases impacting on the hematolymphatic system. Certainly lymphocytic choriomeningitis needs to be included in this group. The lesions are the lesions of acute necrosis in the splenic white pulp. And in persistent infections, there may be lymphoid hyperplasia, but again, this is a disease that it's pretty low in incidence, and the necrosis isn't nearly as severe as it is in ectromelia. Okay, bacterial diseases. Again, probably the most important one to consider is salmonellosis. And the typical lesion of salmonellosis in the spleen is that of our so-called RE hyperplasia or granulomatous inflammation. And here is an example of histiocytic and neutrophilic inflammation in the spleen causing a granulomatous nodule in the spleen. And here's an example of another one. Okay, so this is not the response of ectromelia. This is the response of persistent bacterial infection in the spleen, probably salmonella. And these again would be classified as typhoid nodules. So, as a small differential diagnosis, remember that Corynebacterium may express itself in the spleen by being necrotizing to pyogranulomatous and is embolic. Tisser's disease, the spleen's not involved, all right? And in mousepox, there's extensive lymphoid necrosis in the spleen. And again, non-specifically, septicemia may manifest itself in the spleen. Okay, so sporadic bacterial septicemias, Klebsiella, Pseudomonas, may produce purulent inflammation. Mycotic and parasitic diseases in the spleen, not too many. When we get down to neoplasms in the hematolymphatic system, remember that lymphoma is a very, very common problem in mice. There's an extensive literature. You'll probably see more of this than anything else in this system. Okay, some may have a viral etiology, probably most don't. And the common manifestations of this will be thymic, splenic and lymph node, and then bone marrow, okay? And again, I'm not going to review the histologic classification for you because, partly because I think we can't agree upon it. Okay, this is a typical thymic expression of thymic lymphoma in the animal, so a mediastinal mass, just like you'd have in a cat. Here is look at this. Here is this tremendously enlarged, lumpy, nodular spleen. Again, a manifestation of another type of lymphoma, now manifesting in the spleen of this mouse. And here's an animal that has some splenomegaly, but look at the size of the mesenteric lymph nodes. Okay, so large enlarged white masses in lymphoid organs in mice. We need to consider the possibility of, or the likelihood of one of the lymphomas. Okay. Integumentary system. And I'll go back just briefly to mousepox, considering viral diseases and mousepox. And again, some of you may wonder about the derivation of the term ectromelia, and this really is where it comes from. The Greek term ektrosis means miscarriage, and melos refers to limb, and so the disease got named miscarried limb because of the common manifestation of this was that of infarctive amputation of extremities. All right, and so hence it looked like a miscarried limb. Well, you know, who knows what they were doing back then when they were naming these diseases, okay? But the pathology relates to gangrenous necrosis and swelling and edema of the limbs, and then eventually that results in an amputation, okay? There may be ulcerative dermatitis associated with this, and epithelial hyperplasia, and non-specific dermatitis, and viral inclusions, okay? But certainly the The pathogenesis is quite involved, as I mentioned in earlier systems. This is truly a systemic infection, and infection may run from skin invasion to a replication in regional lymph nodes to a viremia that spreads to liver and spleen, and then secondary replication in the liver and spleen causing splenic necrosis and hepatitis, and now producing a secondary viremia that may go back and cause replication and lesions in the spleen. Okay, so it's quite complex. The outcome of the infection, to some extent, depends upon the ability of the host to mount a cell-mediated immune response, which of course goes back to host strain variability. Okay. Certainly, this is an animal that does have mousepox, but I don't think you can see the skin lesions particularly well. There are some pustular lesions here in the skin. But this is the more classic manifestation of mousepox, and there is swelling and edema of this limb, and I mean there is ischemic necrosis, and eventually this limb is going to slough off. Again, here is another example of ischemic necrosis in this limb, and eventually, boom, it may be gone. So you can see how the early fathers of our profession might have looked at this and thought miscarried limb for some reason or other and gave it that name. Yeah, that may be stretching things a little bit, but try to make it interesting, okay? Okay, bacterial diseases of the skin, and certainly I mentioned earlier that strep and staph dermatitis is a problem in rats. It certainly is in mice, and this is probably related to trauma from certainly bite wounds. And male mice spend a lot of time getting in each other's faces, and so if you house male mice together, there's going to be trauma, and there's going to be secondary bacterial dermatitis associated with it. In the area of mycotic and parasitic infections, certainly mice have their share of mite parasites, and again, I don't want to give you the list of names, but it's somewhat similar to what we see in rats. The common ones in mice are myobia. Okay. I think that's another myobia, and I don't remember the name of the second one. Again, I mentioned in rats and also in mice. I mean, here's a nice example of what dermatophytosis looks like, and here are the trichophytins adhering to the broken hair shaft in this hair follicle. So quite similar to the disease in dogs, right? Neoplasms. Mice do have a similar array of cutaneous neoplasms that rats have. They have Zimbel's glands tumors and lots of sarcomas. The mammary tumors, this is a mammary tumor in a mouse. There is a slight difference between the mammary tumors in rats and mice in that we mentioned in rats they tend to be benign fibroadenomas, and in mice they tend to be adenocarcinomas. They tend to be more aggressive. And lastly, I'm not going to say much about the reproductive system or the musculoskeletal system or the endocrine system, because there isn't really much. But I'd like to leave you with just a brief comment about LDHV, or lactate dehydrogenase elevating virus. This is a toga virus of low transmissibility, now believed to be related, potentially to be related to simian hemorrhagic fever virus. But it's an asymptomatic infection, and the infection may persist for the life of the animal. And the only reason we know anything about this virus is that it causes a persistent, severe elevation in the isoenzyme 5 of LDH. And so, again, although there are no anatomic lesions related to this, that we know of, clearly if you need to be aware of something that may cause elevations of LDH if there's clinical pathology being followed. And also it looks like this virus interferes with reticuloendothelial system clearance, and so that may have ramifications for what you're doing. So a nice example of a common disease that doesn't cause any anatomic lesion, but you need to be aware of it